Hello, hello, EMTB class. We're at chapter 29, head and spine. Yes, that's fine, quite divine. Something else that rhymes with that. I'm a poet, now you know it. So today we're going to talk about the head and spine injuries in regards to traumatic injuries and how we in EMS try and mitigate those types of injuries when we see them and assume that they're there. So this week I want to go ahead and break into the big deal about this is, again, we don't have X-ray vision. We don't have really great diagnostic equipment. I mean, we have good diagnostic equipment, but we don't have the best. We don't have CT scans. We don't have MRI. We don't have ability to draw blood. Some services can draw blood, and they have what's called an iStat that can read lab values in the field, but those are really expensive and nobody really spends the money on them. So what we can do is, if any patient has a head injury or a possible head injury, we assume they have an intracranial bleed and a possible cervical spine injury. So we don't backboard everybody, but we do place people on backboards with high index of suspicion of cervical spine injury and or head injury. And we always transport any trauma patient to a level 1 trauma center. And we always transport these patients in under 10 minutes if we can. 10 minutes or less, every trauma, if we can. Trauma is a surgical disease. It must be treated by a surgeon. As a paramedic, I have a little bit more ability than the EMT. I can splint things, I can give pain meds, and I have a deeper understanding of pathophysiology and stuff like that. However, I'm not a surgeon. While I can splint it, I can't set the bone. I can't put screws or bolts in it. And I can't put it in a cast, and I can't send them into a rehab, and I can't prescribe them pain medications. So I would say that there's a lot that they need to be doing at the trauma center. So 10 minutes or less on scene time. Now, if you've worked any type of trauma yet or something like that, then you'll know that that's a great idea, but sometimes these guys don't just come on out. There's a thing called extrication. Extricating a patient out of a vehicle sometimes takes time. It is challenging sometimes to get these guys out of these vehicles, especially if the vehicle's been crushed in around them. So that would be the moment where you arrive on scene say PPE, BSI, number of patients, mechanism of injury, and then you see how many people you have, and then you look at this car that is crushed to hell and back, and you're like, whoa, I can't get to them. I need to call special heavy rescue with extrication, or in Atlanta, we call them squads. Squads have a extrication style equipment on there. So that's a thing that you know. So that's one of the reasons we call for additional resources. It is really challenging to know all that. It takes time to learn, so don't beat yourself up about it. But I'd rather you call for extra help and not need it than need it and then not have it. Does that make sense? I hope so. So this week we are doing the drug box project being due. We are doing the midterm of inescapable death. It is going to be on paper, in person, live at 5, Tuesday and Thursday this week. So we're going to have that handled this week, and it's going to be a lot of fun. Savannah's going to be in the house. We will represent. And we're going to catch them up on all the labs that they've been practicing in Savannah, but we're just going to verify as their instructors that they are on the right page and right spot. And we're going to take care of all that this week. We're going to be running some scenarios. We're going to be doing some patient assessment. We're going to be doing some spine boarding, some splinting, some stuff like that. It's going to be a lot of fun. I'm excited for you. So let's dig into this thing and see what we got cooking. I'm going to share the screen. Sure. All right, so head and spine, chapter 29. Let's talk about it. So the head and spine, we're talking about some bones in there too. Remember, bones' big job is to protect vital organs. Don't get much more vital than your brain. Your brain needs to be protected at all costs and all times. You have a skull that's job is to protect, excuse me, it's been a long day, sorry guys, is protect the brain. Now the skull is composed of two groups of bones, cranium and facial bones. Now, the funny thing about the cranial or the skull bones is that they protect lobes that they're named after. So the frontal bone here protects the frontal lobe. Temporal bone protects the temporal lobe. Parietal on top here protects the parietal lobe. Occipital back here protects the occipital lobe. And all those lobes have specific functions that they perform for you, the human being. So the brain connects to the spinal cord through the foramen magnum. That is the hole at the base of your skull in which your spinal cord will exit. We just talked about the four bones that make up the cranium, which is occipital, temporal, parietal, and frontal. The face is composed of 14 bones: maxilla, zygomas, mandible, and orbit. I don't expect you to know all 14 bones of the face. I do expect you to know where the mandible's at. That's your jawbone. Mustache max. Maxilla is your mustache area, around this area, the front. Mustache max. Your zygomas are your cheekbones, or as my 1-year-old calls them, cheekies. All right, and your orbits, your eyeball sockets, those eye sockets. Now, if you can nail those down, we'll be in pretty good shape. So again, my expectations for anatomy and physiology for you are not, microscopic anatomy, knowing the dimples on the cells, but I need you just to know the gross anatomy, big structures, so that way you can communicate with other providers on scene and like other providers at the hospital. So these are important things for you to note and that are noteworthy. Okay. Spinal column supports the central nervous system, which is the brain and the spinal cord. The CNS, the central nervous system, is your brain and spinal cord. Central nervous system is your brain and spinal cord. So it supports and protects that. It supports and protects that. There are 33 vertebrae that are divided into 5 sections. Let's talk about it. Cervical, there are 7 cervical spine. Thoracic, there are 12 thoracic. Lumbar, there are 5 lumbar. There are 5 sacral, and there are 4 coccygeal vertebrae. So let's add them up. 7 plus 12. Let's do it, guys. Come on. Do it in your head. I'm going to do it on calculator. All right. 7 plus 12 plus 5 plus 5 equals 4. Now, that's a lot to remember. How can I remember it? So 7, we eat breakfast. Lunch is at 12, so that is your thoracic. Lumbar, we eat dinner at 5. Dessert is at 5, is your sacral. And then coccygeal, there's 4 margaritas after dinner. 4 margs. So to remember, there's 33 vertebrae and where they're at and who owns what. 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral, 4 coccygeal, or that's your tailbone there. So 7 at breakfast, we eat 7. Lunch, we eat at 12. Dinner at 5. Dessert at 5. And we have what? Margaritas. 4 margaritas after dinner. Hell yeah. Now let me erase my mess here. There are 33 vertebrae. What is their job again? Yes, it is to protect the brain and spinal cord, and that is the central nervous system. Oh, yeah. Bring that up. There it is. Kaboom. All right, and there's that again. So, injury to the vertebrae can result in paralysis. Not only do the vertebrae protect the spinal cord, but if they are damaged and squished in, they can actually impair blood flow and nerve conduction through that spinal column. It can result in paresthesia, hemiparesia, paralysis, and other types of forms like that. So weakness, tingling in the limbs and extremities, and paralysis, of course, means that you can't move nothing. Not nothing, nothing. So the vertebrae are connected by ligaments separated by cushions called intravertebral discs. I'm missing one of these. Thank you, career in EMS. I don't know, I enjoy it. I really do. Spinal column is almost entirely surrounded by muscles. Spinal column is almost entirely surrounded by muscles. And muscles play a job in shock absorption, dispersion of kinetic energy, and they do protect also your brain and spinal cord as well. So the big crux of why we're here is that we're here to talk about head injuries. Head injury. Let me just tell you a little something real quick. So let's imagine this is the brain right here, or the skull. Inside is the brain, and there's some blood. Let's change up colors on you. And then down here on the blue, that is your cerebral spinal fluid. So the Monroe-Kelly doctrine, okay, the Monroe-Kelly doctrine states that there is a fixed volume of brain, blood, and cerebral spinal fluid inside your cranium there. Fixed volume, meaning it's fixed, it doesn't move, it does not need to move, it does not need to change. And volume, meaning amount, right? So that doctrine says that if there is any change in brain size or more of the amount of either blood or brain, we will have what's an increased intracranial pressure. So that is the Monroe-Kelly doctrine. Give you a second to write that down if you're taking notes, or if you're just riding in the car with me, pretending to listen while you drive and try not to wreck. Terrible idea, but you got to get it in when you can. I understand. I listen to audiobooks myself. So the Monroe-Kelly doctrine states that there's a fixed volume of brain, blood, and cerebral spinal fluid. Of course, the brain, its job is to do brain things, form function of the body. The cerebral spinal fluid cushions the brain, bathes it in nutrients, and the blood brings, of course, oxygen and perfusion and glucose and all this other crap that's good for it. But if the brain swells due to a head injury, it changes that and it increases the intracranial pressure. And if there's a bleed in the brain, it will increase the intracranial pressure. So there have to have a high index of suspicion for any type of head injury. I've had people that were just kind of bonked in the head, and I'm begging them to go to the hospital, and they don't want to go. And I finally have to get dirty with them, like, you ever want to see your kids again, man? And then I was just using like an emotional rhetoric, but it did work, and I got him there. And he had a slow bleed in the brain. So we have two different types of brain bleeds that can occur. Over here, we have what's called an epidural bleed. So epidural bleed, that is an arterial bleed in the brain. Arterial beating very fast. You'll see symptoms very quickly, and it's usually an involvement of the middle meningeal artery. Epidural, arterial, fast, middle meningeal artery. Those are all buzzwords that you'll need to know. Now, next on this side over here, we have a subdural bleed. Subdural is a venous bleed. It is slow. It can happen over hours to even a day or so. It's a slow bleed. So epidural, epi meaning outside the dural matter, subdural meaning below it. So the epidural is outside of the dural matter, and the subdural is below the dural matter. So what is the difference in the two? This is venous, right? Epidural is arterial. Venous versus arterial. Fast versus slow. Fast versus slow. And these are really hard to recognize in the field, and it's not within our ability really to figure it out which one's going on. But if you bonk your head, I assume you have a head bleed until a CT scan has been done to verify that you do or do not. So traumatic insult to the head may result in injury to that soft tissue, bony structures, or the brain. There is tissue here on the side of your head and on your face and around this area, and that can be damaged and hurt. The bones can be either fractured or depressed in. You can actually have a depressed skull fracture. There's an impression inside the brain. And they account for more than half of all traumatic deaths. Let's pause, rewind, listen. Head injuries account for more than half of all traumatic deaths. Why is that? Because the brain is such a delicate little egg, and if it's popped, it's really hard to get them back. really hard to stop all that damage that's been occurred. The patient may have sustained other additional trauma, but the thing that will kill them is brain, heart, lung not being working. With me? So we have closed injuries versus open injuries. Closed meaning, of course, there's no obvious injury to the brain. It's all happening inside the chrome dome here, and you can't see it. There's no opening. An open injury is there's an opening from the brain to the outside world. You can see his brain chili in there. I'll never forget, I was on scene of a gunshot, and the guy was still kind of guppy breathing. So I'm doing a full assessment. I'm running my hands down his head, and I'm feeling around looking for injuries, decap, BTLS, and I feel penetration in the back of his head. My finger slips up into a skull. Ooh, that ain't good. And out come when I pull my finger out, there's just brain matter all over it. So that's one reason to be a thorough, but also wasn't a whole lot to be done for him. I mean, I kept him alive till he got to the hospital, but it was between him and God. Amen. Amen. So this is often caused by penetrating trauma, open injury to the outside world. There may be bleeding and exposed brain tissue, as I just said, but also anytime you expose the inside of your body to the outside world, there's a huge risk for infection, huge risk for infection. Anytime somebody is stabbed or shot, you think the person that put that bullet in that gun washed their hands? No, there are pathogens on them. Even if they did wash their hands, there's still pathogens all over this place, all over the world. Anytime outside goes inside, we need to be suspecting that there's pathogens carried with it. Falls and motor vehicle crashes are the most common mechanism of injury when it comes to head. Head injuries are often occur in victims of assault, during sports-related injuries, and of course, motor vehicle crashes, motorcycle wrecks. I've never worked one where the person lived. Never. I got friends that have, but maybe they're better paramedics than me. But usually when I get there, they are messed up, bad, really bad. The last one I had, we took the guy to Grady, man, and they cracked his chest, and they had his heart open, and the doctor was in there just squeezing it like this, doing a open heart massage, trying to get his heart to pump. But that dude he was too far gone. Too far gone. Head injuries occur in the victim of assault. Well, yeah, that's right. You know what Bernie Mac said? Bust him in the head to the white meat. That's what he used to say. When somebody hits you in the head, if you get into a big bad assault, people are going for the head. They're going for headshots. We all played Call of Duty. We know headshots count for more damage. So, also more points. So a lot of times it could be an assault victim that was hitting the head with something, or sports-related injury. That's very common too. Being hit the head with a baseball, football, tennis racket, shot put, whatever else is out there. So scalp lacerations can be minor or serious. I'm gonna go ahead and tell you, any scalp laceration could become a distractor injury for you. Why? The scalp and the face are extremely vascular. Extremely vascular. That means I could just slice your scalp a little bit and you will bleed like a stuck hog. It's crazy. And the patient may not even be that bad off. It just looks really bad. It looks worse than it usually is. Now that's if the scalp is lacerated. We don't, if it's a head injury, we're assuming there might be some intracranial bleeding going on. We don't know. We can assume, but any scalp injury will look a lot worse than it is. But because we're going to be thorough, we're going to do a full head assessment, and we're also going to do what? We're going to assume that they've got a intracranial pressure or extreme head injury until it's proven otherwise. Now, they can bleed bad enough to cause hypovolemic shock, and they can be bad, but usually they look worse than they really are. But that's for you to be thorough and not miss these things. Skull fractures, significant force applied to the head may cause a skull fracture. And I can promise you, it don't take a whole lot. It don't take a whole lot. A child swinging a baseball bat, let's take an 8-year-old swinging a baseball bat, clips you on the temple right here, he can fracture your skull. It don't take a whole lot. You know, the skull provides some protection, but it is still, pretty thin bone in certain spots. Like your temple is a very thin area. I think it's less than 2 millimeters thick. So it's very small. So a skull fracture may be open or closed, like we said before. Injuries from bullet or other penetrating weapons often result in skull fractures. I mean, I've seen weirder. I had a guy shot one time. He tried to kill himself, and the thing went around his skull. It was just a small caliber, but he kind of it shot, and it furrowed around his scalp, but never penetrated his skull, and it popped out his cheek. Weird stuff, right? So signs of a skull fracture: the patient's head feels deformed. There'll be a deformity as I'm feeling that old chrome dome, that head. Oh, ooh, this is kind of squishy, or it looks deformed. Like, oh, that thing looks weird. So visible cracks in the skull. Ecchymosis means bruising. It's another word for bruising. Contusions, ecchymosis, it means bruising. So ecchymosis that develops under the eyes, that is an indicator of a basilar skull fracture and possible intracranial pressure. This is called raccoon eyes. The patients underneath their eyes right here will start to darken and darken and darken. It's called raccoon eyes because they look a little raccoon, but they're not. They're a brain bleeding little turd that is dying in front of you because you ain't recognized the raccoon scent. So ecchymosis underneath the eyes, it's forming right there. It's from the blood pooling, right? Remember, ecchymosis is internal bleeding, or bruising is internal bleeding, and it's like forming right here underneath the eyes. That is raccoon eyes, or you can call it by its full name, periorbital ecchymosis. Periorbital ecchymosis. Peri meaning around, orbital meaning the orbital bone here, ecchymosis meaning bruising. So bruising around the eyes is what raccoon's eyes is. So ecchymosis that develops behind the ear over the mastoid process is called battle signs. Another sign or showing of a skull fracture and possible intracranial bleeding would be battle signs. Behind the patient's ear back here, there will actually be bruising that's forming and deepening and darkening in color. It's a sign of what? Of a possible basilar skull fracture, of possible intracranial bleeding and pressure building. It is also free-flowing blood collecting in the tissue behind that ear, and because it's superficial tissue, you will be able to see it. The correct name for that is also, let's see, retroauricular ecchymosis. Retroauricular ecchymosis. It means battle signs. It means blood pooling behind the ear. So now you know raccoon's eyes and battle signs. And here's an example of both. We can see how this young lady has an example of the battle signs, or the raccoon, of the raccoon eyes, or periorbital ecchymosis. And then we got the battle sign here, bruising behind the ears. That's a good showing of that. So linear skull fractures, they account for about, I'd say more than 80, but the book says 80, so we'll go with that. But they account for a huge number of skull fractures. To really diagnose a skull fracture, you need a radiograph or X-ray or something like that. Now, to be honest, in EMS, we're not usually around to see the results of that. It's not very often I get feedback on how my patient did or is doing. It really takes you being good at following up. And part of that is like, I really want to know, but I don't want to violate HIPAA. I hope they did okay. But again, I don't want to go violate HIPAA and just be nosy. It is their business. And that's me being objective. And, while I am curious, and sometimes the hospital staff will tell you, and sometimes if you did a really good job with a patient, the patients and their family will reach out. Again, people don't care how good of an EMT or paramedic you are. They care how you treat them and how hard you work for them and putting your all out effort into it. So that's something we should be very cognitively aware of, at least I think. As you get out in the field, you're going to learn some things that I didn't teach you, and you're going to develop some of your own philosophies. And as long as they are moral, ethical, and legal, that's fine. I have a certain way I like doing things. I'm teaching you the book thing, but you also get some discrete medic stuff too. And I got discrete medic stuff. But 5 + 5 does equal 10, but so does 6 + 4. So if you find a way that is more in line with your habits, as long as it's legal, moral, ethical, and within your protocol, I'm cool with it. All right, let's keep it going. So depressed skull fracture. As you can see on the picture here, the skull is actually depressed down and squished in towards the brain. Now, again, these bony fragments may be driven into the brain, causing more damage. And they're also broken bits of bone. They can be sharp and they can still cause damage. Usually a result of high energy, blunt trauma. We're talking about a baseball bat or something hard and meant to, damage like that. So basilar skull fracture is usually associated with what? That is associated with high energy trauma. Oh, excuse me. Hang on. Usually occurs following diffuse impact to the head. So a big diffuse, like wide spreading impact to the head. So here at the back of the head, we can see the blood coming back here. That's at the base of the skull, basilar at the back. Signs could include CSF drainage from the ears, so fluids, clearish, whitish fluid will come dripping out of the ears. You may have battle signs, may have raccoon eyes. These are things that happen. So open skull fracture, my favorite. Often associated with trauma to multi-body systems. This is your patient that was ejected and thrown from the vehicle, or was shot in the head, or fell down off the ladder and hit their head first. Brain tissue could be exposed. You will get to see some brain chili in your career, depending on how long you do this. There's a high mortality rate. Open skull fractures don't, I mean, there are people that live, obviously, but it is a higher chance of you dying. It depends on a lot of things, a lot of factors. How good an EMS crew you got, how fast they get to you, how fast they get you to the trauma center, and how good your doctor is. There's a lot going on there. So TBI, or traumatic brain injury. TBI, or traumatic brain injury. So this is most serious of all head injuries. This is the most serious one. It's the worst one. It's the bad one. We come back to the Monroe-Kelly doctrine. The brain has been injured, so there is a fixed volume of brain, blood, and cerebral spinal fluid. With a TBI, there's going to be a changing of the guard. Either there's going to be more blood because of a leak in the chrome dome, or there's going to be a swelling of brain tissue. Either one will increase intracranial brain pressure. So we got primary direct injury and secondary indirect injury. Primary results from instantaneously from impact to the head. Secondary brain injury increases the severity of the primary injury. Let's talk about it. Secondary injury may be caused by hypoxia, hypotension, cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, and infection. Now you can see how all these may cause brain injury and traumatic brain injury, and they're not from actually something actually just hitting you in the head. Hypoxia could be the patient that stopped breathing because he overdosed on some narcotics. Hypotension. If the brain doesn't get blood flow due to a drop in blood pressure for whatever reason or some form of shock, brain doesn't get blood, what happens? I tie a string around my finger. It turns red, blue, purple, black, and dies. If the brain does not get blood flow or low blood flow, it will have tissue start to die. Cerebral edema is that the brain tissue itself is starting to swell and fill with extracellular fluid, and it will fill in those third spaces. Intracranial hemorrhage, either something hit you in the head or you had an aneurysm. Remember, an aneurysm is usually caused by uncontrolled hypertension, a weakened part of vessel wall inside your head. Remember, you left the water hose on too long of the high pressure system. It formed a titty on it. The titty popped. Now there's bleed inside the brain. Increased intracranial pressure will cause a decrease in amount of blood flow going to the brain. It can squish the brain, and eventually the brain will herniate. So the brain's sitting here. Remember that little tiny hole at the base of the skull, the foramen magnum? When the increased intracranial pressure grows and grows and grows, the body will try to compensate. So it will try and drop the pressure. So it will try to herniate by pushing the brain through that tiny hole. The patient usually will start to posture. They'll do what's called decorticate posturing, where they'll draw up like this. Decorticate toward the cord. Decorticate posturing is toward the cord. They come in like this and they start posturing. Decerebate posturing happens later. And decerebate posturing is an extension. Their arms go out like this and they start to extend and they start to posture. It looks a bit like a seizure, but not quite. It's more of a posturing. And remember, decorticate is toward the cord. Decerebate, their arms are open wide because they're flying to Jesus. And that's all. There's not much you can really do about that, but monitor them, protect the ABCs, get them to a trauma center level 1 with neuro as quick as possible. Cerebral ischemia can do it, and infection. So the brain can be injured by a penetrating object or indirectly as a result of external forces. So the coup contra coup, let's talk about that for a minute. Is there a picture? There's usually a picture in these things. There's not. Look at that. Weird. All right, so coming back to this. Let's focus on this word right here. So coup contra coup. What we're saying is this can result from striking a windshield. A lot of other things can cause it, but that's the most common one. And that's also the one that there's usually a picture of. So basically, I want you to imagine a guy, hitting the brakes, your head going forward. As your head goes forward, your brain slides forward and slaps the front of your frontal bone here. It slaps the back of your forehead. Boom. Now that pressure, that momentum carries you forward, bang, your brain slaps into the front of your forehead here. And as you revert back and are thrown back from the impact, your brain shifts to the back of your skull and hits the back of your head. So the brain goes boom, 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 coup, contra coup, coup, contra coup, coup, contra coup. Does that make sense? I hope so. So what'll happen is you'll damage the front of your brain here by it slamming into the back of your forehead, and you'll damage the back of your brain back here by it slamming into the back of your skull back here. So again, the most common thing is head hits the windshield, brain comes to an abrupt stop by striking the inside of the skull, head falls back against the headrest, brain slams into the rear end of the doohickey there. Cerebral edema may not develop for several hours. That's true. It couldn't, but it can develop rather quickly too, and it could be aggravated by low oxygen levels. So what you don't want your traumatic brain injury patient to do, you don't want them to be hypoxic. So keep that O2 sat over 94%. Traumatic brain injury, keep their O2% over 94%. Keep them from being hypotensive. Give them a fluid bolus. Give them a fluid bolus, or get your medic doing it. I mean, y'all can't start IVs as Vs, but your medic can. He needs to be thinking about a fluid bolus. He needs to increase the pressure to the brain. He needs to increase the pressure to the brain. Because when the brain swells, right, it's swelling. There's the pressure in here so high, those carotid arteries that normally feed your brain and the intravertebral arteries that normally feed your brain, they're having trouble pushing blood through that through that area because of the pressure in the brain. It's too high. So the body's first response is to increase your blood pressure. And your job is to keep that blood pressure up so you can perfuse the brain. As long as the brain's perfused, there's a chance. Keep oxygen levels up, keep them from hypotension. So avoid hypotension, hypoxia, hypoventilation. I like it. So cerebral edema can develop quickly, but it may take hours. And monitor the patient for seizure activity. Seizure activity is usually a later sign of when they're actually herniating, or when the brain is under a lot of duress. It causes like a focal electrical storm, and the patient will start to have a full-blown seizure. Now, if your medic's on scene, he can give an anticonvulsant, a benzodiazepine called Versed, Valium, or Ativan, his choice, whatever his company carries. But your medic can stop that. So if you come on scene and there's a TBI going on, I hope you've already called for ALS with your additional resources request. I hope they're there quickly, and I hope they can stop the seizing, because you can imagine, remember, having a seizure does. When you seize, you don't breathe. When you seize, you don't breathe. And when you don't breathe, you don't bring in oxygen, and the brain will become hypoxic, and all your muscles and stuff are doing what? They're becoming hypoxic as well. So this is all a bad thing. So intracranial pressure is the accumulation of blood within the skull or swelling of the brain that will rapidly increase the intracranial pressure of the brain. Remember the Monroe-Kelly doctrine. There is a fixed volume of brain, blood, cerebral spinal fluid. If there's an increase in blood or an increase of brain tissue, the cranial pressure will increase. So increased ICP squeezes the brain against the bony prominences within the cranium. Increased intracranial pressure, or ICP, will squeeze the brain and damage it. So there are signs of intracranial pressure. Again, I assume every head injury has a brain bleed until proven otherwise. That's just me keeping a high index. So we got Cheyne-Stokes respirations, ataxic and Biot's respirations. These all are indicative of a increased intracranial pressure. Now, Cheyne-Stokes is the patient will breathe faster, 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 and then be apneic. Breathe faster, 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 and be apneic. So they breathe, and then they're apneic. And then ataxic or Biot's is just really crazy looking breathing pattern. They're breathing all over the place. They'll be apneic for a second, then breathing everywhere. Ataxic, A means without rhythm. So they don't have a real rhythm. So the main, and I gotta be honest with you, this is just me, street medic. Come here, look at me. in the field. In the field. I can't see their dang breathing rate real good anyway. I'm just telling you the truth. I mean, I hate to say that. It makes me sound like a terrible instructor. I'm just giving it to you straight. It's really hard to see in what exact rhythm they're in, but it's really easy to see that they are breathing irregularly. So if I have a patient that's, let's say they're spider webbing on the windshield, they were in a car wreck, they're kind of altered mental status right now, and they're breathing kind of funny, I can assume it's due to increased intracranial pressure, because that pressure in the brain, remember the respiratory system is driven by the brain. The medulla oblongata is sensing changes in what? The chemoreceptors in the brain. It's looking for changes in the pH and in the CO2. Now imagine the brain's being squeezed, right? It's being squeezed. Do you imagine squeezing the brain would throw off the receptors a little bit and decrease blood flow to that medullary area and that brain stem area? Because that's where the breathing actually comes from, is your brain stem area. So it would throw it off a little bit. To be honest with you, it's hard to see what kind of exact respiratory pattern they're in, but you can see that it's irregular. So irregular, bad juju, right? Go ahead and erase this and we'll keep on moving and grooving. So decreased pulse rate, headache, nausea, vomiting, alertness, decreased alertness, bradycardia, sluggish or non-reactive pupils, decerebral posturing, and increased widening pulse pressure. Cushing's reflex. Let's talk about Cushing's now. So Cushing's reflex is three things that occur. You got 1, 2, 3. One of the first things that occur would be the systolic blood pressure will start to climb. That is the body's attempt to do what? It's their body's attempt to auto-regulate their need for blood flow to the brain. If you go more than 10 seconds without blood flow to the brain, you will be unresponsive, unconscious. So your body, when there's an increase in the cranial pressure, will develop a Cushing's reflex. And the first thing that happens will be the systolic blood pressure will jump up in an attempt to continue perfusing your brain. While this happens, it also widens your pulse pressure. Widens your pulse pressure. So what does that mean? Widened pulse pressure. So the pulse pressure is the difference between the systolic and the diastolic number. 120/80, that sounds good. That's only a difference of about what, 40? Not a big deal. But 220/80, that's a big difference in those two numbers. That is a widened pulse pressure, and that's one of the things you'll see. So widened pulse pressure, bradycardia. As the brain gets squished, the heart will respond by slowing down and bradying down. And this probably has a lot to do with the losing of sympathetic tone from the compression of the spinal cord. And it might have to do with, well, that's too deep for y'all, so I'll keep it away from that. So we've got systolic increase, widening pulse pressure, bradycardia, and then we got, I'm gonna bring it up here so you can see it. I'm gonna go ahead and put irregular respiratory pattern. That's a terrible R. Man, I'm a terrible drawer. Y'all should complain about me. Y'all could, it'll be no good. Irregular respiratory. We'll just put irregular resp. You know what I mean? So again, you can't really see what's going on, but Cheyne-Stokes or ataxic bias respirations or central neurogenic hyperventilation syndrome, those are the main three you'll see with a increase in cranial pressure. Again, as the EMTB and as someone who's just being street level with you, it will be really hard to see which one's really going on, but you can see irregular respiration. So Cushing's triad or Cushing's reflex is these three things: irregular respirations, bradycardia, which means the heart rate drops below 60, and then a increased widened pulse pressure by the systolic jumping up. So widened pulse pressure, bradycardia, irregular respirations. That is your Cushing's triad, Cushing's reflex. The reflex's job is what? It's trying to compensate for the increase in cranial pressure and keep this patient alive longer so maybe they can get the care they need. What do you think? Sounds good to me, Josh. Hell yeah. So bleeding inside the skull will also increase ICP. The bleeding can be between the skull, the duramater and outside the brain, or within the tissue of the brain itself, actually inside the brain meat. Now remember, to pad the brain. What do you mean pad the brain, Josh? That's a lot going on. So the brain is padded and protected by the meninges. and they are the pad that protects the brain. So the pia mater, I'm a terrible speller, that's an A. The pia mater, that is the innermost, most delicate. Pia, I think, means small, right? So pia mater is a small innermost layer. Next, you have the arachnoid space. And the reason it's called arachnoid space is because it's so veiny, it looks like spider webs. And then you got the dura mater. So pad, P-A-D. These guys pad the brain. The meninges pad the brain. The pia mater, arachnoid, and the dura mater. Now, if you're ever confused, remember the dura mater is the outermost layer. It is a durable, most durable and toughest membrane you have, or excuse me, meninges you have. These things can actually get infected. You can have what's called meningitis. You probably have heard of meningitis. It is an inflammation of the meninges, and this is a very common registry question to get thrown out. So while I'm thinking about it, I'm going to tell you, meningitis is usually an extremely stiff neck or nuchal rigidity. That's the fancy medical word for stiff neck. Nuchal rigidity, headache, kind of blurred vision, and a fever. You got a patient with that going on, make sure you glove up, make sure you put a mask on, make sure you observe all standard precautions and then some, because it might be a meningitis patient. You do not want that. Horrible way to die. If you are going to get meningitis, at least pay your tuition first. That way I can benefit from your death. I'm kidding. I'll miss you. So I've already talked about epidural bleeds, but this is an accumulation of blood between the skull and dura mater. And it usually involves who? The middle meningeal artery. The middle meningeal artery is, of course, the artery involved. Epidural bleeds are arterial. They are quick. They are fast. You'll see symptoms really fast and quickly. Subdural bleeds are slow, can take hours to days to develop and bleed because the venous system is low pressure and it doesn't flow as quickly. So nearly all of these epidural bleeds are the result of a blow directly to the head that produces a linear fracture. Very common. However, you would not know this. You would know possibly that there's a bleed in there. You would suspect a bleed. You would treat for a bleed. But without a CT scan, you don't know exactly what, when, or where the bleed is doing or what's happening with it. Subdural bleed. That's accumulation of blood beneath, sub meaning below. Subdural, the dura mater, the protective layer around the brain, the meninge. So this is blood beneath that meningeal barrier. And of course, epidural, epi means outside. That is a accumulation of blood between the skull and the dura mater. And subdural is actually blood flow beneath that. All right, intracerebral hemorrhage. Let's talk about it. That is actually bleeding inside the brain itself, bleeding inside the brain tissue itself. That can usually occur from a penetrating trauma to the head or because of rapid deceleration forces. So rapid deceleration forces is what? All right, so imagine my phone's in the car. As I stop on a dime like that, your body's thrown forward and your body is attached. Your organs are attached by ligaments and your brain by a spinal cord. If you are thrown forward hard enough and your seatbelt or something stops you quick enough, it can cause what's called a deceleration injury. So if I'm going this way, but my body's going this way now, it's going to tear. It will cause tearing. So if you're thrown forward, but your seatbelt pulls you back, what's going to happen? Tear. You can tear your liver open. You can tear your spleen. You can tear your intra-aortic artery here. You can tear your brain stem off of it. You can really die really quickly. So we didn't talk about subarachnoid. Well, we hadn't talked about them. So subarachnoid hemorrhage, that's bleeding in the arachnoid space where the CSF circulates. Remember, CSF stands for cerebrospinal fluid, and bloody cerebrospinal fluid, it'll show signs of meningeal irritation. The patient will have a lot of irritation and a lot of pain from that. That can be caused by trauma or an aneurysm. So concussions, we can talk about concussions real quick. So a concussion, a blow to the head or face may cause concussive damage to the brain. Closed injury, usually with a temporary loss or an alteration of the brain's abilities to function without demonstrable physical damage to the brain. About 90% or more patients do not experience a loss of consciousness. It's just a blow to the brain. They just have now developed temporary or altered abilities of their brain to function for a little while. A patient with a concussion could be confused, have amnesia, and usually concussions don't last very long, but you need to ask symptoms. If somebody hit their head, ask if they've been dizzy, weak, they're having double vision, nausea and vomiting, ringing in the ears, slurred speech, inability to focus. These are signs of a concussion. So let's say you're working a football game. Let's say you're working Georgia Tech, something simple. Dizziness, weakness, the guy's hit. Are you feeling nauseous? I'm a little nauseous. I could hear something ringing. No, that's the band. Nope, it's not the band. It's you. Slurred speech and the inability to focus. That patient's got a concussion. They need to go and just chill out for a little while, let their brain heal. A contusion to the brain is far more serious than a concussion. It involves physical injury to the brain tissue. Remember, a contusion is bruising, so bruising on the brain. It may cause long-lasting or even permanent damage. Depends on how hard, how much, and how often they're hitting the head. A lot of football players and wrestlers have developed brain contusions from being slammed and bammed and pushed and pulled and injured throughout the years, and it's not been pretty. One of my favorite wrestlers growing up, Chris Benoit. Everybody assumed he died a couple years back, and everybody thought he was on. It was a steroids and crack thing that happened, that he just went ballistic and killed his family, like his wife and kids and stuff. Come to find out, he had a very common injury of brain contusion that caused swelling and change of personality and violent outbursts, and it really wasn't him. So he killed himself. I think he killed his wife, and I think a couple of his kids survived or something like that. But it was a pretty terrible, horrible event. I'm sorry to share it with you if you didn't know about it. You can look it up though. But they're thinking that at this point it may be something to that effect. Anyway, so other brain injuries, they can arise from medical conditions such as blood clots or hemorrhages. We've talked about stroke, but just a quick recap. A cerebral vascular accident, or CVA, is a stroke. Over 85% of strokes are ischemic in nature, meaning a clot has blocked blood flow to an area of the brain, and that area of the brain is not getting blood flow. So it's going to start to malfunction. The patient would exhibit signs of facial droop, arm drift, muscle weakness, slurred speech, and other things like that. Now, your job is to recognize it early and treat the patient by getting them moving and grooving towards the stroke center so they can have reperfusion therapy quick as possible. Now, there's another type of stroke that we talked about when we talked about stroke, but the one that we'll incur upon today is the hemorrhagic stroke. That's when a vessel in the brain pops. We have increased intracranial pressure, internal bleeding, and the patient will show stroke symptoms because a popped artery in their brain. Spine injuries. Compression injuries can result from a fall. Just because you fall and land on your feet, all your body weight compresses those spine, those vertebrae slap and squish together. You can very easily compress the vertebrae, herniate a disc, and push it out of its normal alignment. You can break vertebrae. There's a lot of things going on there. Not only that, you can have motor vehicle crashes that can overextend the spine and stretch you out. That actually would probably feel very good to me right now. Ooh. Rotation, flexion injuries from rapid deceleration. These are all things that can happen here. When the spine is pulled along its length, we call it hyperextension. And any one of these unnatural motions, as well as this latter excessive bending, can damage the spine. So when these spine things are altered out of their normal place and their traumatic forces are upon them, they can fracture and move out of place. So 3 general principles of dealing with a head injury. Establish an adequate airway, regardless of what's going on. ABCs. Remember your ABCs. Airway is first. We have to establish an airway. A lot of these patients don't die and suffer brain damage because you don't intubate them, because you can't. They will suffer and have brain damage because you didn't recognize an airway management issue or an airway threat to their life quickly enough. These guys will suffer brain damage and die because you did not ventilate them. You, the EMT, can insert an OPA or an NPA and ventilate them and perfuse their body. You need to control bleeding and provide adequate circulation to maintain cerebral perfusion. So don't let them become hypoxic. Don't let them become hypotensive. A lot of that as an EMTB, you have limited scope to deal with, but you can bag and you can say, hey, paramedic, let's start an IV so we get the pressure up. We need to keep the pressure up. And also you can assess the patient's baseline levels of consciousness and continuously monitor them. And more than anything, you're going to have trauma questions like this. I'm going to give you the answer to all of them. The number one most beneficial thing that these patients can get is for you to get them to a trauma surgeon. Trauma is a surgical disease. Get them out of that scene within 10 minutes if you can. So manage the airway, form a jaw thrust, open the head. Pretty much everything we've been talking about. Maintain the head, cervical spine in neutral inline position. With a trauma, you're going to want to do a modified jaw thrust, not a head tilt chin lift. Trauma gets the modified jaw thrust. If you suspect cervical spine injury or head injury or spine injury, put a C-collar on them, long spine board and backboard. As a matter of fact, we're doing backboards this week. You're putting each other in backboards. I'm tired of it. It's happening. You've reached that point in your career. It's doing it. All right. So if there's any foreign bodies in the airway, secretions or vomitus, get it out. Pull it out. For adults, you want to suction with the yonker, that Harry Potter looking one. Suction it out. Pull things out. Only suction as far as you can see, right? And that big yonker is good for pulling out foreign bodies, secretions, teeth, vomitus, big chunks of stuff. Use it, but never suction for more than 10 to 15 seconds because it can cause bradycardia. One, by stimulating the vagus nerve, and two, by sucking the oxygen out of their lungs, literally. So don't suction for more than 10 to 15 seconds. For an adult, 15 seconds max. For a child, 10 seconds max. For a neonate baby, 5 seconds max is all you're suctioning. You're only suctioning what you can see. You never go farther than that, and you're only suctioning on the way out. So as you suction on the way out. Don't suction going in, suction on the way out. So give supplemental oxygen to that patient. Circulation. If the patient's in cardiac arrest and has no pulse, obviously do CPR. Active blood loss will aggravate hypoxia because if there's no blood to carry oxygen, that will aggravate hypoxia and cause hypovolemia, and they'll die. So stop any active bleeds that you can. You can almost always control scalp bleeds with direct pressure. You most of the time, yeah. If not, you can always hold that direct pressure there, and I sometimes will wrap a pressure dressing around the head to put pressure on there for me. Shock is usually a result of hypovolemia, so the only way you can fix that as a provider is to understand that the situation is critical. Trauma is a surgical disease. Transport them to a trauma center quick, fast, in a hurry. And then remember what Cushing's triad is. We got increased blood pressure, decreased heart rate, irregular respirations. It'll be change Stokes or biaps. You're not going to be able to see which one in the field anyway. Manage shock, which means lay them flat, put their feet up at 6 inches, put a warm blanket on there, give them O2, ventilate if they need ventilating. And that's the end of the day. Gas money, dude. We're going to stop sharing now. So head injuries can be quite complicated. There's a lot going on there. The best thing you can do for your patient, guys, is to recognize they have a head injury, maintain a high index of suspicion that there could be a brain bleed. And again, unless you got CT scan on your truck, you don't know. Again, subdural bleeds are slow. They can happen over time. And by the time that guy gets home, he could wake up dead or not wake up at all. So avoid hypotension, avoid hypoxia, manage the airway, and you should be in good shape. Also be practicing your DCAT BTLS and what it means, because this week you'll be doing some trauma scenarios. Oh yeah. All right, well, that's going to do it for the night. I'll post lecture number 2 later this week. I'm running out of time. I got to go put 1-year-old and 4-year-old to bed. So that's going to do it for me, guys. Y'all be safe. We'll see you at lab this week. I'm excited for you. Don't forget the midterm and your drug box project. And y'all behave. Text me or email me if you need me. Peace.